Welcome to our December 2012 Orthopedic Grand Rounds. Today we're going to be talking about total hip replacement, and the title of the talk is From Sir John Charnley to the Present, Have We Made Progress in Hip Replacement? And it's my honor to introduce our three speakers. We're going to first have Dave Zeltser come up, who's an R4, and Dave is going to briefly review the history of total hip replacement. After Dave, we're going to have TJ Tanous, who's a clinical assistant professor of orthopedics, and he practices at Northwest Hospital. And TJ is going to talk about the history of surgical approaches for hip replacement. And then finally, Dr. Manne, who is the associate professor of orthopedics and also practices at the university and at Northwest Hospital, is going to talk about the evolution and future of bearing surfaces. And some of this I know Paul has also been working on and presenting to the FDA. So thank you. Dave Zeltser.
Thank you, Dr. Chansky and everybody. So I'm going to start out by presenting briefly three challenging cases, which we will return to at the end of the talk. And then I'll give a short history lesson kind of to provide some perspective on the modern era of hip replacement surgery. And I think that when I'm done, you'll find that nothing that we have now is really so new. Everything has been invented and tried by someone previously. Dr. Tanous will then discuss surgical approaches, and finally Dr. Manne will end with bearings. So our first patient to discuss is a 30-year-old female with end-stage hip arthritis. She comes to clinic complaining of pain for the past year. She has a history of developmental hip dysplasia, and she had femoral and acetabular osteotomies at the age of 2 and 3. Otherwise, she's healthy and her BMI is 25. Her preoperative radiograph is shown here, showing her left hip arthritis in the setting of dysplasia. Our second patient, KL, is a 24-year-old female with a history of Perthes disease. She underwent a varus derotational osteotomy at the age of 9. She presents to clinic with severe hip pain, limiting her activities of daily function. And again, here's her left hip showing severe arthritis and deformity of the head and neck. And our third patient is LP. She's a 60-year-old female who had a femur fracture about 30 years ago. She was morbidly obese, but had a gastric bypass and lost a significant amount of weight, but still her BMI is 35 and she has other medical problems, including diabetes, sleep apnea, heart disease. She's had both of her knees replaced. Her preoperative radiographs are shown there, showing her femoral fracture malunion. And so I just wanted to put some numbers to what I think everybody already knows. The demand for hip replacement is increasing. Currently, more than 1 million primary total hip arthroplasties are performed worldwide. From 2005 to 2030, the annual rate of primary hip replacement in the United States is projected to increase by 174%. Also, the annual rate of revision total hip arthroplasty is projected to increase by 174 and 137%. Another point worth mentioning for this talk is that our patients are getting younger. By the year 2030, half of all total hip arthroplasties are projected to be done in patients who are under the age of 65. So now I'm going to do a brief history lesson on the early days of hip replacement. I'm just going to touch on the highlights, not everything. So as early as 1891, the German Gluck, pictured here, described a hip replacement using materials of ivory, nickel, and plaster of Paris cement. He had high rates of infection and loosening, and that really compromised outcomes early on. In the 1920s, we all know Smith Peterson popularized a procedure known as mold arthroplasty. And mold arthroplasty was where you take a cup of synthetic material, and originally he did use glass, and this was interposed between the ball and the cup. The material would then be removed at a later date, and that would leave behind presumably a layer of fibrocartilage. And here's a follow-up radiograph of that post-op patient. Those are various materials that he used kind of over the years. Among other problems with the design, the glass material would break, and so interest shifted to other materials. And in 1938, Vitalium, which is a cobalt chrome alloy, was introduced. This allowed the material to remain in the body, and there's the Vitalium mold arthroplasty in place. So that same year in London, Philip Wiles treated 6 patients bedridden with Still's disease and inflammatory arthritis with the first metal-on-metal hip replacement shown there. And this device had significant problems with bone resorption and loosening. And so he went back to the drawing board and redesigned it, but the second generation version was really not any better, and he had poor results, and those were mainly due to stiffness of the hip, bone resorption, and loosening again. So in 1940, we really have our first metal hemiarthroplasty, and Bowman and Moore implanted this custom-made long stem Vitalium hemiarthroplasty to reconstruct the hip after resection of a large giant cell tumor of the proximal femur. This particular patient didn't do well. He developed a prosthetic-associated infection, a periprosthetic fracture. The whole thing was taken out. He did poorly. And then in the 40s, in France, the Judet brothers developed a more anatomically shaped femoral head replacement made of acrylic. And basically, you resect the femoral head, and then this prosthesis goes into the femoral neck. And notice that this had a short stem, and this was pressed into the neck. The plastic on the left there had a tendency to fracture, and so the Judet brothers later reinforced their prosthesis with steel, as shown on the right. And here's a preoperative radiograph, hip arthritis, and the post-op with the steel reinforcement in there. So 3-year results were reported in 1950. Results were an improvement over earlier procedures, but still 2/3 of patients required an assistive device to ambulate. And so there were multiple problems with the prosthesis, and in an effort to improve upon some of the drawbacks of the Judet prosthesis, in particular the ability to control version, anaversion, restore neck length, and increase durability, a long stem Vitalium hemiarthroplasty was developed also in France in the 1950s. But once again, loosening of the prosthesis remained a major challenge. And so back in the United States, in South Carolina in 1950, the Austin Moore prosthesis was introduced, and this represented really an important advancement in the design of femoral components. 5-year results were good or excellent in 10 out of 12 arthroplasties with the Austin Moore prosthesis, where they also had reamed out the acetabulum. And this was one of the first studies that showed that resurfacing the acetabulum at the same time could really improve results. And around that same time in New York, Frederick Thompson introduced his Thompson prosthesis, which was a Vitalium hemiarthroplasty. At follow-up, patients were doing okay, but they still suffered from weak abduction, and many required a cane or a crutch to ambulate. And so in the decade of the 1950s, several acetabular replacements were brought to market. These were generally fixed to the pelvis with some combination of screws or wings. And there's just a few representative samples shown there. Also in the 50s, we see reports of acrylic cement being used to bond prosthesis to bone. Finally, I'll mention, in the early 1960s, the McKee-Farrar total hip replacement was introduced, and this was a metal-on-metal articulation that combined the Thompson stem with a metal cup, and it used cement for fixation. And unfortunately, it suffered from poor manufacturing quality and poor metallurgy, et cetera. And so this brings us to John Charnley, and he was working out of Manchester, England. In the 1950s, he did extensive basic science research into hip replacement. He started out thinking about the Judet prosthesis, which we had just talked about earlier. And the Judet prosthesis had this problem where it would squeak for a while, and then the squeaking would stop. And many at the time felt that this was due to joint lubrication. It was a good thing. But Charnley believed this was incorrect. Instead, he felt that this was happening because there was so much friction at the articulation between the prosthesis and the acetabulum that the prosthesis would essentially bond to the acetabulum, and then any hip motion you're getting is occurring through a loose prosthesis, through a loose interface between the plastic and the bone. And so his first attempt at a hip replacement was essentially a resurfacing of both sides of the joint with a thin layer of Teflon, which is another type of plastic. Unfortunately, this didn't work because the prosthesis placed too much pressure on the femoral head, leading to avascular necrosis, bony collapse, and then loosening of the prosthesis. So next, he tried developing a Teflon acetabular cup shown there, and this would articulate with the Austin Moore femoral prosthesis we just talked about. Around the same time, Charnley was really interested in the idea of cementing the femur, and he had two main reasons. Number one, he thought it created an even contact surface between the prosthesis and bone. And the second reason he liked it was that he felt that by sealing off the medullary canal, it would prevent the spread of infection down into the bone. And then the next modification he made was actually a result of suggestions by his engineers, who recommended using a smaller head and therefore a thicker Teflon. And as you recall, this is a much smaller head. The Austin Moore prosthesis is a much larger head. And this modification from his engineers was, the rationale for this had two main reasons. Number one, a smaller head, they said, would create less frictional torque and therefore less loosening, and then a smaller head would allow you to have a thicker Teflon acetabulum, which would presumably last longer and not wear out as fast. So in the 1960s, the Charnley prosthesis procedure, the operation looked like this. There was a trochanteric osteotomy for exposure, and this required protected weight bearing for the troch osteotomy to heal. A press fit, Teflon cup, cemented stem. At the time, patients were staying in the hospital an average of 8 weeks. But the good news is that at a year, his patients were actually doing great. Unfortunately, at the 2-year follow-up, people weren't doing so well, and that was mostly due to failure of the Teflon cup. And so this failure of Teflon prompted Dr. Charnley to switch to a different material, and he chose high molecular weight polyethylene, and Dr. Manne will talk about that some more later. And so in November 1962, the Charnley low friction arthroplasty was born, and the key aspects of the low friction arthroplasty were high molecular weight polyethylene acetabular component, small diameter femoral head, and then he cemented in both components. The 4 to 7 year results were fantastic, and 90% of patients were pain-free, 80% were ambulating an unlimited distance. 10 years later, these great results were essentially sustained. And then we had 2 large long-term 25-year follow-up studies published by Barry and colleagues and Callahan and coworkers in 2002 and 2000. And these 25-year follow-up studies of Charnley's prosthesis showed 81% and 77% survivorship. Results like these were really unparalleled at the time by other orthopedic surgeries. And it was observed that total hip arthroplasty indeed might be the orthopedic operation of the century. Charnley, at the time, established his low-friction arthroplasty as the gold standard for hip replacement. However, obviously, since this time, the options available to joint surgeons has expanded immensely. And just as a representative example, implants now vary by shape and surface, coatings, architecture, modularity, etc. So this is my last slide, and I want to leave you with this. As the patient population indicated for total hip replacement becomes younger and more active, as well as patients live to be older and have more medical comorbidities, orthopedic surgeons encounter some of the same challenges that were faced by Charnley's predecessors in earlier slides, including the age-old problems of implant failure, loosening, infection, and material wear. So thank you. Now Dr. Tanous is going to discuss surgical approaches.
Thank you. I'll cover a few of the, almost all the approaches that are available to the hip. We'll spend a little bit more time in what I would consider more of the modern approaches to hip surgical approach. I think this is a hot topic right now, and Dr. Manne has the other really hot topic, which is bearing surfaces. And these are things that patients actually come in asking about, which seems kind of crazy. And I'll challenge you with this first slide, which is guess the approach. It's 4 different total hips done through 4 different approaches. And I don't think you can tell the difference looking at it. And I think that can kind of sum up what I'm going to tell you at the end, which is putting the implants in the right position is of utmost importance. And so we'll briefly go through some of the approaches, associated complications and advantages. And then we'll go over some comparison studies and say, can we look at our literature and will it help us tell us what approach is best if there is an answer to that. And so, like a lot of things in orthopedics, lots of people try and tell you different ways to do things. Look this way, no, go that way. And they think their way is the best. That being said, these are the traditional ways that we've looked at hip replacement, starting with the trochanteric osteotomy that Charnley did, the modified lateral positions, anterior lateral, posterior 2 incision, and direct anterior. And in fact, the last 4 are the ones we'll spend the most time today going over. So the trochanteric osteotomy was popularized by Charnley for hip replacements. Gave excellent exposure, but the abductor was kept in continuity. However, there were obviously issues that you would expect anytime you take the trochanter off with non-union, and those 8-week hospitalizations due to trying to get this trochanter to heal back prior to mobilization. The lateral approach was an improvement on that, and that was keeping the abductor intact, but removing a partial or partial detaching the gluteus medius, still allowing to keep the trochanter in place, but get enough adequate exposure to see the hip. The anterior lateral was just a slight modification of that, which is going slightly more in front of that between the gluteus medius and the rectus. It allowed you to come out through the front for the dislocation. As you can imagine, the advantages are lower dislocation rates associated with that procedure, but there was some questions of abductor dysfunction, most of which would resolve with time. Because of some of the abductor dysfunction, people look to going more toward the posterior aspect of the hip, going through the short external rotators in the back. In this case, the hip is dislocated and the large, thick capsule in the back is removed. And as you can imagine, because of removing the really strong capsular tissues in the external rotators, there's an increased risk of needing dislocation, potential questions of increased offset associated with to get stability of the hip to prevent dislocation, potentially more muscle damages. But on the flip side, it was more extensile and was familiar to most, as it's one of the more common approaches that is taught in residency training programs. Direct anterior approach, which we've already mentioned, Smith-Peterson, who popularized this approach for approach to the hip in the past, has recently become more in favor in use for direct anterior and 2-incision total hip replacements, because it's really the only true internervous plane that we have in the hip. And it goes between the tensor fascia and the sartorius. And as you can see from this next slide, that it can require a lot of special instrumentation. And in fact, these people look like they know what they're doing, but if you come to some operating rooms, they're running around like they have no idea what to do with this table. So it definitely has some disadvantages because it may be specialized equipment. There are some things we'll talk about here in a second about some studies and people who've started to use this approach. It's less familiar. It's done more in pediatric patients. And that's where most people have seen that approach, but it's quite different in adults who are heavier set in general. The advantages, the ones that are touted and on those billboards and on those websites, is that you don't cut any muscles and less muscle damage, and you can get away without any precautions. And here's a few studies that will look at people who looked at this anterior approach using a fracture table. You can see quite a large number, 800, single surgeon, but you can see quite a few complications, stroke fractures, acetabular fractures, and still has dislocations despite going through what's considered to be a more stable approach. Wound complications. Another one, 200 consecutive total hips. So once again, still with dislocations, mostly from stem subsidence, wound infections. They didn't see any correlation between gender, age, or BMI in this particular. And then the 2-incision, which is the acetabular approach, is similar to the direct anterior, but the femoral is between the gluteus medius and the piriformis. It does require special instrumentation and specialized training. So some of the same things that the direct anterior has, which is the special instrumentation, it's less familiar to people, and it's probably not for all patients. The advantages are lower dislocation, faster recovery, and less muscle damage. And in fact, we have a few studies here that show that it seems to have pretty good results. There can be some complications, and this is to be expected in learning curves with a new procedure. And this is another surgeon's first 200 cases, and just showing what things can happen in those early cases. And so there are lots of complications associated with different surgical approaches, and these are just some of the common ones that can be associated with almost every approach. And so the question is are you confused or just not impressed? And maybe there's an app for that. Well, there's not. And in fact, this is one thing that we lack quite a bit of, which is a lot of really kind of randomized, controlled type trials for approaches of the hip, mainly from biases from surgeons. So I don't know what approach I want to do. So let's look at the literature. And there's lots of things out there that can help guide you on what the safer approaches are. And this is a study out of England looking at over 1,000 hips. And anterior lateral versus posterior. In this case, in the 5 years, they really saw no difference. Revision rates, dislocation rates, didn't matter. Head size didn't make a difference in dislocation. So, and here's another study that was done here looking at just match pairs, looking at it. And they thought that maybe the 2-incision actually got a little better, the posterior a little quicker. But the posterior had a little less OR time, probably because it was more familiar to the surgeon, and blood loss. And here's one out of here at our institution looking at a single surgeon series with the 2-incision versus the Hartingen approach. And really basically showing that this is a pretty safe approach and can get similar component position, which we mentioned at the beginning is very important in both groups. But then the Mayo Clinic has a group of a very small number that they really looked at gait and strength and showed no difference between mini posterior and 2-incision. They repeated this again at a year, and they did show a little smaller improvement in hip flexion strength, internal rotation strength, and single leg stents in the mini posterior, but of course a small study. But I really don't want my hips to dislocate. Well, we already showed you one study. And here's a large one from the Rothman Institute looking at direct anterior lateral hips and so very low. And these are patients that had no precautions. And so they didn't use any elevated SIPs, abduction pillows, or any restrictions, and a very low dislocation rate. So the anterior lateral approaches, when done at a high volume center where people who have good experience with that can get really good results. So okay, but I want them to recover faster and not dislocate. So now you want to add, you're asking for more than just one thing. And so there's a couple of studies that now show that you can look at direct anterior versus direct lateral. They seem to have better functional differences at up to 1 year. But after 2 years, there's really no difference. And that's through a direct lateral, which is usually not the second go-to incision for most of these people. Most of them are doing posterior or anterior lateral as their other option. But I want to do less muscle damage as well. And so there are a few studies out there, not a lot, but there's some MRI studies, and this is looking at anterior lateral versus through a minimally invasive versus a direct lateral. And there does appear to be less muscle damage associated with that approach through an anterior lateral, as well as one with a direct anterior approach. I'm sorry, this is a study looking at muscle inflammatory between a posterior approach and direct anterior. There seemed to be less muscle damage through these through the blood markers associated with the direct anterior approach. And then can I save some money? Well, how can you save hospitals money? You can use cheaper implants, or you can do what most people try to do is get people out quicker. And Dr. Manne's study as well does show that you can lower hospital overall costs by doing an approach that gets people out of the hospital sooner. So in summary, there's lots of different approaches. The direct anterior 2-incision, anterior lateral and posterior incisions can have very similar outcomes in experienced hands. The 2-incision direct anterior do have a potential for quicker return to function and less muscle damage. You should do what you're what's most comfortable with. And if you do decide to switch, visit surgeons, attending cadaver courses. If at all possible, have an experienced surgeon scrub your first cases. So now we'll have Dr. Manne come up and talk about bearing choices.
Thanks, TJ. That was a really nice explanation of all these different approaches. So the last thing we're going to discuss is something that's a fairly hot topic in joint replacement nowadays, and that's the sort of what bearing surface should we use. And this is a little bit of a modification of a talk that gave to the FDA about 6 months ago, although hopefully it's a little bit more entertaining than what I said at the FDA. So the question is, are these new bearings a new hope, or are they the dark side? Is this the yin yang of good versus evil? Are we taking the bad with the good? And the short answer is we simply don't know. A quick mention of my disclosures: I don't have any. So the fundamental goals of any joint implant are to relieve pain, restore function, and fix whatever problem exists with the joint. And then secondarily, the implants have to be simple to put in. You want to try to not injure the surrounding soft tissue, and you want to be safe. The implants have to be easy and cheap to manufacture. They have to be durable, and you have to be able to fix them if something goes wrong. And we keep bringing up John Charnley, but the fact is that Sir John was very prescient. And it's interesting when you go back and read some of his original papers, because he really predicted most, if not all, of the problems that we're facing today. And he pointed out very reasonably that if you're going to put in a mechanical implant into a patient, the surgeon, the implant manufacturer, and the patient have to make some level of compromise in terms of activity and what they expect to do. And the fact is that you simply can't expect to put something in that's going to last 30 years and allow the patient to play soccer. So initially, back in the 60s, we confined surgery to patients who were so badly off that they were basically on sticks or in a wheelchair. And essentially, the only other option was a girdle stone. But the extraordinary success of hip replacement has allowed us to extend this to almost any patient with a bad hip. And we've changed a lot of what we allow patients to do, as you can see from this recent survey of hip and knee surgeons. We allow patients to engage in sports. We allow them to exercise. We allow them to return to high demand activity, including things like martial arts and contact sports, which I think is probably not a terrific idea. But the fact is that when we look at the old implants, okay, the Charnley that was done through a relatively unsophisticated approach, the fact is these things last an extraordinarily long time. And of the patients that were still alive at 30 years, 80% of them still had their original implant in place. Hard to do better. And in fact, this is not just the orthopedic operation of the century. This is actually something from the rheumatology literature. And what the rheumatologists will say is, this really is the greatest advance in rheumatology up until the advent of the disease-modifying agents. So these are about the same age. Without any maintenance, care, or attention, they last an extraordinarily long time. So the question is, what's the problem? We should end this discussion right now. Well, joint replacement is not entirely benign. This is a short list of some of the things that can go wrong. And if you do enough of them, you'll see every single one of them. And failures do occur. And in fact, when Tom Fearing's group looked at their revision practice, they looked at about 750 joints and found that almost half of the revisions were done within the first 5 years, either because of instability, loosening, infection, or fracture. So a lot of these were related to surgical technique, but a lot of them were also related to the implant itself. The other problem is that patients now want and expect a perfect result every time. But reality intrudes. And as of a decade ago, this is from the Academy monograph from 2001, as of a decade ago, fingers pointed at the plastic liner as the weak link. Now, polyethylene is, I would say, currently the material of choice as a bearing surface. It's commonly used on an industrial scale, and basically it's used in Coke bottles, it's used in cutting boards, it's used in a huge number of consumer products, and only about 1/10 of 1% goes to orthopedics. This is a little bit of a concern because there's really only one manufacturer left, so hopefully the lawyers don't get to them. But the question is why polyethylene? And Dave touched on this a little bit, that Charnley originally chose Teflon as a bearing surface, but anybody who's inadvertently taken a nonstick frying pan and scraped it with a metal fork knows what happens next, which is all of a sudden you no longer have a nonstick coating. And the problem with Teflon is that it sheds extremely quickly, number one, and number two, it causes an exuberant soft tissue reaction. So in fact, polyethylene was the next choice, and the reason for it was basically serendipity. Charnley's engineer Craven was talked into it by a guy who was selling gears, and Charnley basically said, what the hell, let's give it a try. And polyethylene does work, but it's not perfect. It's variable in terms of its quality. It oxidizes, it fatigues, it chips, and it eventually breaks down, as you can see here in a knee replacement. And bone loss or osteolysis was seen almost instantly with total hip replacement. And initially, this was felt to be secondary to the use of cement. And in fact, it was called cement disease. And we spent an awful lot of time and money trying to get rid of cement, only to find that it exists with any kind of bearing and any kind of implant. The issue, though, is not really the wear per se. It's really what the body does in response to the debris. And typically, the presence of any foreign material will cause a variable response, depending on the composition of the material and the size of the particles involved. So a big particle, which is sort of arbitrarily over 1 micron, causes typically granuloma formation, while small particles activate the immune system. It's a little bit of a complex process. Those of you who have done the in-training exam know a little bit about that. I'm not going to cover that too much, but I am going to cover what the strategies have been to reduce wear. And the first is the section on the top, which is to design things better and to reduce mismatch and lack of tolerance between components. And the second is to create a better bearing surface, either by changing or eliminating the polyethylene. So let's look at strategies for improving the polyethylene, and this is the good, the bad, and the ugly. Well, We'll start with the ugly first. Poly 2 was a carbon fiber reinforced plastic which failed disastrously. It was extremely hard to make. It did not have any particularly good fatigue resistance, and it demonstrated no clinical improvement. And this is what it looked like after a year or two in the patient's body. And it was withdrawn from the market soon after introduction. Hylimer was introduced in 1989 as a new alternative with higher crystallinity, which was thought to provide better wear resistance, and it was specifically targeted to younger, more active patients. And the result was osteolysis, bone loss, which was substantially worse than with conventional polyethylene, and it was withdrawn from the market after a short period of time. So the newest approach has been to chemically modify the polyethylene to improve its wear properties, and in the last 10 years or so, this has become an important approach, and it does seem to work. Essentially what polyethylene is a long chain of carbon and hydrogen, and what cross-linking does is it makes links between these different chains, and as a result you wind up with a presumably stronger implant. Caution is warranted though, because cross-linking is typically performed by radiating and heating the plastic, and every manufacturer does things a little bit differently, and it's not always possible to ask the manufacturer what exactly they're doing because these are proprietary processes. Again, design of materials and manufacture materials is a compromise, and the problem here is that better wear is typically accompanied by a decrease in mechanical properties. So in the 1990s, we had a lot of questions regarding the optimal bearing surface, and we had very few ways of figuring out what was going on in vivo. But in the early 1990s, we had a well-known example of a hard-on-hard bearing, which was the McKee-Ferrard. Now, this implant was not used for a very long time. It was not particularly well designed. It had sharp corners. It didn't have particularly good offset. The manufacturing was crude. The stem was manufactured in a different plant than the cup, so the two didn't really match up terribly well. And the way you put this in was you mixed up some cement, you took it and jammed it into the bony surface with your thumb, and then jammed the prosthesis in there, and that was pretty much how you put it in. So you would expect that this thing is not going to work very well. On the other hand, you have a 28-year survival of 74%, and in fact, when you look at first-generation implants, the McKee-Ferrard beat the gold standard Charnley at 20 years. So the clinician's viewpoint in the early 2000s would be as follows. Number one, I don't have a particularly good solution for my younger, more active patients, and I'm seeing a lot more of them. I know that a lot of the improved polyethylenes are much worse than what they told me was going to happen. If I get rid of the polyethylene, I can use a bigger head and reduce the risk of dislocation. So what about using a hard-on-hard bearing? So we know now, or we knew then, that the wear in simulators was 1 to 2 orders of magnitude lower with the hard-on-hard bearings. So let's take a look at the ceramics first. And these are very hard. They have extraordinarily good wear characteristics. If you put them in a simulator, survival is 99.9% at 50 years. We're pretty much done. It's not surprising that they're hard and that they're durable. Why? Well, natural aluminum oxides are sapphire and ruby, depending on what trace metals happen to be around. And so just like precious stones, the ceramics are attractive, they're heavily marketed, and boy, are they expensive. But there are drawbacks aside from the expense. Let's take a look at a couple of them. First of all, they break at a rate of about 1% per year, even though manufacturers will swear that they never happen. Well, they do. This is a case that we saw a couple of years ago that was about 2 years after surgery. And here's what we found at the time of surgery. And basically, both the acetabular component and the femoral head had shattered into a whole bunch of pieces. And we spent a couple of hours picking glass out of this patient's hip. In addition, certain designs have a very high propensity to squeak. And although that sounds kind of funny, if it's your hip that squeaks and every time you take a step you're making a noise, you're probably not going to be all that happy. So what about metal on metal? Well, we can get rid of the plastics, we can get rid of ceramics, because we know from the McKee-Ferrard that metal on metal doesn't cause problems. Or does it? Well, again, the story is not so great. Dept introduced the ASR in 2005, and internationally, both a resurfacing and a replacement were offered, although in the United States, only the hip replacement was approved. Zimmer specifically marketed its Duram as the solution for young and active patients, and this is actually from their literature. This was implanted first in 2006. But the failure rate for these implants approached 15% within the first 2 years in some series. The ASR was awful. There is no other way to put it. And this is the data from the Australian registry before it was taken off the market. This was the data from the Australian registry on the Durham. The last Durham in Australia was put in a year ago. It's essentially off the market now. So what went wrong? Well, there are a few things that were in common with these implants. First of all, the implant was very thin, the acetabular component, so it deformed on insertion. The second problem is that it's extremely shallow, so it overloaded the edge. And then lastly, for whatever reason, the implant manufacturers didn't put any porous coating around the periphery, so the implant never grew in. Not terribly smart. So what happened? Well, as one would expect, our attorney colleagues jumped in, and they were happy to help our patients. But on a serious note, a lot of patients were subjected to inferior implants with a poor outcome. So maybe not. Unfortunately, removing the plastic doesn't remove the possibility of bone loss. This is an x-ray of a 50-year-old man who was resurfacing, was performed a few years ago by a designer surgeon who has been doing this for 30 or 40 years. And you can see that there is a substantial degree of bone loss. And in fact, when this patient came in to see me, I told him he should have this done now. Or he could wait for it to break, in which case it would be a lot harder. So there's also significant concern about serum levels of metal, and so this isn't just a localized joint problem anymore. The literature is pretty clear that cobalt and chromium represent the most toxic possible choices. And it's also apparent that a dose response is present, similar to what's been demonstrated with polyethylene. Below a certain level, metal particles are tolerated and show a low level of toxicity, but above that level, there's a sharp increase in cell death and both local and systemic toxicity. We're also seeing the emergence of clinically significant adverse local soft tissue reactions such as pseudotumors, and women, for whatever reason, seem to be at particular risk here. And then additionally, despite very low wear rates, osteolysis still occurs even in well-functioning stems, and if you look at postmortems, for example, you'll see frequent unappreciated femoral bone loss around stems that are apparently well-fitting. So the problem is apparent, because when we take these bearing surfaces, we're kind of throwing in apples and oranges and a few grapefruits and pomegranates together. And the implant on the left, which is a Metasul small diameter, is not at all the same as the Birmingham hip resurfacing on the right. And so the question is, should we group them together? And the short answer is, probably not. This is registry data from Kaiser, and what we see here is that the metal on metal is actually the winner in terms of longevity of the implant. And when we look at other registry data, such as the Australian registry, we see contradictory data as well. It's true that the big metal on metal hips are not doing well, as we see on the left, but in fact the small metal on metal bearings, as we see on the right, are doing just fine. So there may be some questions as to whether this is a head size issue or whether this is a modularity issue rather than a bearing surface issue per se. Another issue to consider is that orthopedic surgeons will, with a great deal of prodding, respond to the literature. Not easily, but we will. For example, in 2009, Kevin Bozik's group reported on the epidemiology of bearing surfaces, and he noted that the most common bearing at that time in a Medicare population was metal on polyethylene. About half patients got a metal on poly, followed by metal on metal, about 35%, and then ceramic on ceramic, which was about 14%. By 2012, you can see that the numbers had changed dramatically, and essentially almost nobody was doing metal on metal hip replacements. The other question is cost effectiveness. There's a real push to be cost effective, and what you see here is the cost of the bearings alone at University of Washington. And what you see here is that the use of a metal on metal or ceramic on ceramic bearing increases the cost of the bearing, the implant substantially, and can double the total implant cost. And this takes us from an institution that can make a small margin on Medicare cases to one that loses a couple of $1,000s on every case. So no question that, as TJ pointed out, we're really trying to do this better, faster, cheaper, and it's quite clear that at least from a cost point of view, the hard-on-hard bearings are not the way to go. In addition, the newer bearings don't seem to be substantially different in terms of durability or complications, and their expense is such that any potential reduction in risk of revision is minimally cost-effective. So there's another point here, which is the patients are different, okay? And maybe we shouldn't be treating the guy on the left the same as the gal on the right. The question there, therefore, is, the final question is, how trusting should we be of new technology? And when industry presents us and says, this new bearing, this new implant is better than anything else, how trusting we should be? And I would say the short answer is we should not be trusting at all. We should trust no one. We should demand proof. And as one of my mentors told me, never be the first to the party and never be the last one to leave. So never be the first one to adopt a technology, but never be the last one to adopt a technology either. Why don't we go back and look at the cases there. 30-year-old female with end-stage of arthritis, femoral and acetabular osteotomies at the age of 2 and 3, and this is her x-ray here. TJ, what would you do? I mean, would you do anything different here?
Well, obviously this is a young patient, and so, I think these patients are going to come in with lots of copies of what implant they think they need and what approach. And so a lot of times, I think most of the time you're going to spend is counseling appropriate expectations. And so this is probably obviously someone who will end up with a hip replacement. I do occasionally talk about hip fusion, which we didn't really talk about, but I think it's something that we should be discussed with patients. Most of them are not very happy or excited about thinking about it, but I think it's something. And then I think bearing choices is really something that I go with each patient individually, and it's something they have to be comfortable with what their options are and basically all the risks and benefits of all of them. I think in this particular case, I stay away from metal on metal in females. I basically refuse to do it in those patients. I don't think it's a good, so ceramic on ceramic or even a ceramic on polyethylene bearing.
Time for a question. So that's a pretty strong statement, and why do you explain to the rest of us why, particularly in women, you wouldn't use a metal on metal bearing?
If you look in the registry data, as Dr. Manne pointed out, women tend to have an enormously higher risk of developing those adverse local tissue reactions with metal and bearings. And I think especially in a woman of childbearing age, I think the risks are too high. I just don't feel comfortable doing that. There are some people in town who will do that, and so if they're really adamant, I'll send them to see one of those patients.
Are there any studies, or can you tell us a little bit about what the literature says about using those bearings in women who may get pregnant? Any evidence of crossing the placental barrier?
I think both Amstutz and what's his name in England?
McMahon. Yep.
McMahon both have patients, but I don't know if I've seen anything written that says that they all tell you they've had several patients who've had and they've had no problems, but I don't think there's anything published there.
Yeah, I mean the short answer is these the metal ions that we're talking about here are very, very small, and they do cross the placenta. And Derek McMahon's been asked about this a number of times, and his response is, well, we've done this in 20 patients of childbearing age, and we haven't seen any horrible deformities yet. I mean, that's not enough for me to hang my hat on a metal on metal bearing. It's not entirely clear why women have a higher adverse soft tissue reaction to these implants, but there's no question that they do. There are a number of series that demonstrate that the incidence of pseudotumor is dramatically higher in women than it is in men. It may simply be a question of women's immune system is slightly different and is tuned a little bit higher. I'm not sure whether that's the case or not. The other issue is that the bearing surface in women tends to be a little bit smaller because you're using a slightly smaller implant. And we know from registry data that the smaller hip resurfacings do not do as well as the larger diameter hip resurfacings. In this case, that's a very short neck. I think you would have a very tough time restoring leg length in this patient, which she would like to have. So the resurfacing is not going to give you that unless you sort of leave it perched. So I think that a resurfacing in this case would probably not be the way to go. With respect to the bearing surface, I think it's a dealer's choice. I typically use metal and polyethylene because I know the most about it. I don't think there's anything wrong with doing a ceramic on ceramic or a ceramic on polyethylene. So in this case, this is in fact what we did. And we did get a little bit of the leg length back. So this is a a proximally porous coated titanium stem. It's a cobalt chrome femoral head articulating with polyethylene. So this is pretty much what I do typically. We did get some leg length back. I don't think we restored it exactly, but she's pretty happy with the fact that she's closer. So the next is a 24-year-old female. Underwent a varus derotational osteotomy at the age of 9 for Perthes disease. And this is what she presents with. This is actually a case that's upcoming. I haven't done anything with this yet. Have at it.
Yeah, so,
Tell me what to do.
Lots of young patients. So I think these cases, which anyone who's had a varus derotational osteotomy, I get very concerned about the proximal anatomy, and so would like to have something available if I need to change my inversion. Because if you end up with one of these, sometimes I'll have 40 or 50 degrees of inversion on the femoral side, and that can be pretty challenging with a primary stem, even just a Wagner type stem or even a revision type stem to allow for, or an SROM type stem to allow you to change the inversion independent of where the stem fits. It's pretty ectatic in the proximal. These cases are going to be challenging on the acetabular side. It's hard to tell, but there may not be a whole lot of posterior wall. So you may be ready to use part of that femoral head and recreate part of the superior wall or the posterior wall if necessary. So these are challenging cases. Not my first case of the day. Typically, if they'll be later in the day. Bearing choice, I think, once again, I think what we talked about before would kind of stand in these patients. And these young patients, their expectations are pretty high, and they expect a normal hip. And I think expectations is really still the number one on these patients. But I think that I'd be prepared for the worst, but hope for the best on one of these kind of cases.
So what equipment would you bring into the room for this case? What prosthesis?
Well, I would have my traditional proximal wedge titanium proximally coated stems, but I would also have a revision style stem that I could use, that I could individually dial in the inversion if necessary. For the acetabular side, I think most of us are using titanium porous ingrowth stems or cups, and I'd probably have screws and whatever else I need to recreate the any deficiency of the acetabular portion. And typically may have metal augments available as backup, but in a really young patient, if you can get some ingrowth of their own bone using their own head, that'd probably be advantageous in this case.
This is sort of my plan. I think the cup side, I think, is going to be relatively straightforward. One of the nice things that we have is with the porous metals, like the trabecular metal, is that that can really save your bacon a lot of the time, because you can get reliable bone ingrowth with less than 50% host bone contact. The biggest problem that I see here on the femur is this varus deformity, and if you look at where, hopefully I can do this without. If you draw a straight line in a normal hip up the shaft, you can see that the exit point is the piriformis fossa there. The problem in this one here is if you draw that line, it winds up over here somewhere. And because of this osteotomy, the entire proximal femur is malaligned with the shaft. And the problem is if you try to put an entry point here, you're going to destroy the greater trochanterior, and you're going to destroy the abductor sleeve as well. So this is not a case that you would try to do through a mini approach, through a direct anterior, or what have you. In fact, what I'm planning to do on this case is redo the osteotomy, but instead of doing a varus derotational osteotomy, I'm going to do a valgus derotational osteotomy and put it back the way it is before they screwed around with it. Because that way I can get a fully porous coated stem all the way down the pike. So plan is go ahead and get this prepared, do the osteotomy basically where the initial osteotomy was done, and then essentially use this as an intramedullary rod so that I could fixation top and bottom. And I've done this a few times before, and it works reasonably well. But it's essentially what you're doing is creating a fracture of the femur. So there's a little bit of some sleepless nights associated with that. Then the last case is also one of mine, as it turned out. So this is a 60-year-old female who had a femur fracture about 30 years ago. She's got a host of medical problems, so she's a typical UW patient. She's obese, she's diabetic, she doesn't have the greatest lungs, she doesn't have the greatest heart, her knees have already been done, and she presents with this. And the problem here is that, fortunately on the lateral she's pretty straight, but you can see here that the tip of any stem you put in is going to wind up down here. So the question is now what do you do? So I guess putting you on the hot seat one more time. What are your options here?
Well, this is the advantage of being able to look at these beforehand and templating. And so there are some stems that are a little bit shorter that I would template it. And I had one of these come up recently. And it's always nice to throw templates up from different manufacturers of different implants. And they do make stems that are shorter that you can use that can do that. You could, conceivably use a resurfacing. You wouldn't have to care anything about that at all. And I've done that for high proximal femoral fractures. And so I would probably look at just using, there are some stems that are somewhat significantly shorter that may get you through that area that still have good track records at 5-10 years. So that's probably my first thing before talking about doing an osteotomy or something, because then you're really getting really long there, I think.
I want to congratulate all three presenters on their excellent lectures.
Research.
I have a question pertaining to the body mass index. Again, that's a common problem in mobility impaired patients or not. And again, the question that we're always faced with is, should we encourage our patients to lose weight, however it is done surgically or so, before we intervene surgically? Or should we give them the benefit of doubt and possibly incurring a higher perioperative morbidity, do the reconstructive surgery in hopes that with appropriate guidance, the patients will do better afterwards? And maybe I'll ask Dr. Zeltser first and put him on the spot what his opinion about that is as an unbiased newcomer into the field, and then ask the two experienced surgeons in sequence. So Dr. Zeltser, what is your opinion? Should we have an obese patient lose weight first before we give them the surgery, or should we somehow try to veer through it? What's your understanding?
Yeah, I think it does depend on how obese, the number. The number is important, but I think for most patients, definitely a conservative approach at first is important in counseling and diet and nutrition, and getting weight down should be the first step as part of conservative treatment of hip arthritis. But ultimately, I think that unless BMI is super high, and not everyone has their own kind of cutoff or thought about that, I think that doing a hip replacement in someone who has a high BMI, after trying conservative modalities to get that down, is reasonable to proceed.
What is that magic number, that magic BMI?
That's a good question. I don't know. I don't have an exact number.
There's no exact number.
There's no exact number that I know.
Is there a relative number? Meaning, would you give a patient the benefit of saying, look, you've lost 10 pounds since I've seen you for the last half year. That's pretty good. That's good enough to go? Or
I think like a BMI of 50 is probably too high, and a BMI of 35 is kind of in that area where if you've done your best job, then we can probably help you. But
would you be more flexible in your stance if the patient had significant other problems, such as a flexion contracture or significant bony erosion? Would that soften your absolute numeric stance, which is a relative one, as we now discover?
I don't know. I'm not sure.
All right, so let's go to the gentleman
It's
to
tough.
your left there, Dr. Tanous. So how rigid are you, and what is your advice in terms of mobility first and show me compliance versus let's give you some musculoskeletal help, let's get you moving again?
It's not very rigid. I don't have any absolute cutoffs for BMI. I think that the spine literature shows that people don't lose weight after surgery. And so, because a lot of people, that's the first thing they say, well, I can't exercise because of my knee, and I point to there's literature to support that. The extremely obese, I do try to encourage them to at least get counseling through at least a bariatric surgeon or nutritionist initially, just as, I think that's the thing. But whether or not I make them wait until they lose 100 pounds before operating, if they're getting up into the 50, I'm pretty hesitant. But I have a lot of patients in my practice that are in their BMI of 35, and a lot of them aren't, they know they're overweight, and a lot of them aren't really that motivated to do that first. I just find that a lot of those patients are, that you can keep seeing them back, and they're still complaining about their knee or their hip. So I'm probably a little bit more lax than some.
So let me ask
But I do counsel them on the increased risk associated with obesity and infection and revision rates, and go over all that, the information for that, so that they're aware of that.
Right. Howard?